Good morning friends. Today we will be discussing about a new video of revision of Roux-limb gastric bypass for weight regain, in which we do a limb distalization. So this patient was a 35-year-old male who weighed 136 kg with BMI of 42.4. Patient had undergone Roux-limb gastric bypass but gained 35 kg. Patient was attempted conservative treatment with multiple counselings and weight loss conservative management, but patient wanted a pediatric surgery vis-a-vis all other options, including injectable weight loss drugs was also discussed. We had lot of options for surgical options. We have for revising a failed RYGB, we can do a pouch revision with gastrojejunostomy trimming, or we can band the pouch, or we can do distalization, or we can convert it into a BPD duodenal switch or a Sadis procedure. We chose distalization of RYGB versus others, as in them the other two malabsorptive procedures like BPD duodenal switch and Sadis, we would have to create a gastric anastomosis. So we got in the routine workup, we got the endoscopy done, which was almost normal. Small gastric pouch was there, it was not enlarged, pouch was not there, anastomosis was not much enlarged. And then we also got the gastrographin study done. In that also we could see a small gastric pouch which was directly draining into the jejunum. So here we have three components in a Roux-limb gastric bypass. This is the original configuration. You have a small gastric pouch, then we have a alimentary limb which is 50 to 100 centimeter generally, and then we have a biliopancreatic limb which is 100 to 150 centimeter, and then we have a common channel which we do not measure in normal Roux-limb gastric bypass. Now in a distalization of RYGB, we do not touch the pouch or the gastrojejunostomy. We just directly go where the alimentary limb is joining into the biliopancreatic limb, divide that alimentary limb and bring it down, and then measure the common channel which is there, and then from the IC junction minimum 300 centimeter, you can go 400 also, common channel limb is taken. So this is the OT layout. We generally have a split leg position, surgeon is in between the legs, then we have a camera assistant which is on the left side of the surgeon, and then the first assistant is on the right side of the surgeon, and it's a reverse tended work position. So we take generally 4 ports. All these umbilical right hand left hand working port are little bit down than the Roux-limb routine Roux-limb, because we don't have to dissect the hiatus area or the pouch area. We just have to manage the small bowel only. So we did the diagnostic. We could see these adhesions, small bowel adhesions which were there to the falciform ligament and to the liver. So we are doing a sharp dissection, and we should have good endovision. So this is this pouch which is stuck to the liver. So we have to note and assess the routine anatomy. We have to identify which is the alimentary limb, which is the biliopancreatic limb, do the adhesolysis. So this is the alimentary limb which is going into the anastomosis, and then we have a common channel, and above is a biliopancreatic limb. So we'll just mark these areas which are there, and you will be able to identify. So this is the anastomosis which is there, and then it is below, it is going into the common channel. So it is, anatomy is well defined. So we have to know the anatomy well. We should not get confused between the alimentary and biliopancreatic limb, which can create a disaster post-operatively. So then we have to measure the total common channel which is there. Ideally it should be measured from the IC junction, start from IC junction. So this is the common channel which is there, and it should be accurately marked. So what we did was we used the thread to 10 centimeter thread. So here this is a stapler which is being used to divide the alimentary limb, so that which will be going down. So this is the IC junction, this is the 10 centimeter marking has been done, and every 10 centimeter we are going and measuring it. In this, when we are measuring this, the port position changes, in which the right hand working port which is on the left side of the patient becomes the camera port, and the umbilical port and the left hand working port becomes your working port. So otherwise we are on when we are doing the anastomosis, again we change the camera. So this is the 300 centimeter marking which we have done, and here we will be anastomosing the limb, that is the alimentary limb which is we have divided, and anastomose here. So this is a stay suture we are taking, so that it is oriented well and we can fire the stapler easily. So this is we take a stay suture type of a thing and then hold it with the instrument. So here we are doing an enterotomy with the help of a hook, and then with the help of a dissector we dilate it, and then we use generally a triple stapler technique of creating a jejuno-jejunostomy. This is the first stapler. Then the second stapler is fired from the left hand working port. That's why we take it as a 12 mm. And then the third stapler is fired after taking 3 stay sutures, so that we can close this enterotomy with the help of a stapler. The advantage of triple stapler is the twisting torsion is less, and it's a wide anastomosis is there. And then it is very important to close this mesenteric defect, internal herniation site, and it has to be done through a non-absorbable suture and in continuous manner, starting from the bowel till the base of the mesentery. And so this anastomosis is done. We did not place any vein. Thank you from learning laparoscopic surgery.